The following episode is brought to you by the American Urological Association.
Good afternoon. My name is Jay Raman, and I am Professor of Urology at Penn State Health and Chair of the AUA's Office of Education. It's my pleasure to host another episode in our educational podcast series, with this specific episode being one of our areas that focuses on a domain within the core curriculum. Today's show title is specifically Focal Therapy Options for Prostate Cancer, and it's my pleasure to have as guest Dr. Ruben Olivares. Dr. Olivares is Associate Professor of Urology, and he is the prostate cancer focal therapy lead at the Cleveland Clinic in Ohio. I had the pleasure of getting a chance to meet him in person just about maybe 8 weeks ago at our Fundamentals in Urology course. So it was nice to meet in person then, and it's nice to reconnect now to do this podcast. Ruben, big thanks in advance for your time.
Hi, Dr. Raman. I would like to say that thank you for having me here. I think that we can spend the next few minutes talking about focalized ablation for prostate cancer.
So, when we talk about ablation of prostate cancer, I feel like even before we get into maybe focal therapy, maybe before we even talk about patient selection, it may just be helpful to take a step back and really understand what's the rationale. What's the rationale for focal therapy? What's the rationale for thinking about the concept of ablation, even if it's beyond, say, a focal area in the prostate? Maybe talk to us a little bit about why focal therapy, what do the guidelines say, and what is the rationale underlying it?
Yeah, I think it's important to discuss or to have a better understanding what is the potential role, why we are doing this, and also the evolution, why we came until this point. Nowadays, our patients diagnosed with localized prostate cancer are facing a dichotomous option. For one side, you can offer monitoring, very close monitoring, active surveillance. And in the other hand, if the patient has more high-risk features, we offer the whole removal, the radical treatment or irradiation. But we are concerned about the risk of over-treatment or under-treatment, because on one side, we just keep an eye, and the other side, we remove everything. We have now a good opportunity, and that's why focalized treatment is living like a momentum, because we know exactly where the prostate cancer area are localized inside the prostate. What is the volume? How close or far are from important structure, for example, the external sphincter or the neurovascular bundle or even the bladder neck. So it looks like a lot of effort using MRI and fusion biopsy to diagnose a more aggressive cancer if we, at the end, we just remove the whole gland. Nowadays, I would say we have a better understanding of the source of energy that can very effectively just destroy, ablate the area compromised with cancer.
So I think you've highlighted, I think, a really important point, which is, in the last 20 years, specifically the last 10 years probably, prostate cancer has increasingly evolved to a type of malignancy where we have, in many cases, imaging that allows us to better map out the disease. As you sort of alluded to, size of the lesion, location of the lesion within the prostate, and obviously we know from a lot of the fusion biopsy studies, the accuracy of identifying the clinically significant lesion is certainly better now than it was, say, 15 or 20 years ago. Would you agree with that?
Yeah, unfortunately, I mean, yes, you are completely right. In terms that all the innovation comes from diagnostic pathway, first, and after that comes the treatment pathway. Nowadays, we have a better risk stratification. We are more confident that we know exactly what is inside the prostate. So now that we have a better understanding of the imaging and the way that we can reach that area within the prostate, make a lot of sense that the next step will be, safely and effectively destroy that area.
So I think even before we dive into sort of the ideal patient for, say, focal therapy or ablation, talk to us a little bit about this concept of the dominant lesion. I mean, obviously, the goal of imaging like MR is to identify the most concerning or suspicious areas on the prostate, this, quote unquote, dominant lesion. Talk a little bit about how good is MR guided imaging and sampling to identify the dominant lesion, and then also the corollary to that is the dominant lesion and the cancer biology for the prostate cancer. Could you talk about both of those?
Yeah, I mean, focalized treatment, the concept of focalized treatment, it's been for a while. And the one of the disadvantage to offer that treatment was the multifocality of prostate cancer. And we all know that prostate cancer tends to be multifocal in 85% of times. But now we have a better understanding of the natural history. Not all the area within the prostate behave the same. So the first thing that we can discuss about focalized treatment, that we change, that we are aiming for completely control of cancer to delay definitive treatment or delay progression. So if we think carefully, if we treat one area of the prostate that can drive the metastatic spread, what we are aiming is to delay definitive treatment, controlling cancer instead of the full cure of the patient. I would say that the tools that we are currently using are not perfect. As we all know, there is no many things 100%. And the MRI and biopsy tends to, for example, underestimate some volume. So what I'm referring to is that with the tools that we have available, we can compensate the inaccuracy of the MRI and the biopsy, improving the risk stratification. For many studies that compare MRI imaging and whole gland specimen from the radical prostatectomy, we know that the MRI tends to underestimate the volume. That's why the biopsy is very useful, because we can take a few samples of the main core of the abdominal lesion that will drive the metastatic spread. And at the same time, if you are thinking in the focal therapy landscape, you will take some sample from the margin and of course from the contralateral side. With that, we have like a mapping. We change the paradigm from just detection to risk stratification, so we can deliver a safer treatment.
So just talk as we sort of conclude this segment, just sort of educate our listeners as to what do the guidelines say right now, and I think I realize I'm asking you this, but I also realize that there isn't necessarily consensus amongst the guidelines, whether you look at the NCCN versus the EAU and the AUA. So maybe just give us, our listeners, a sense of what are the guidelines saying, and then maybe we'll sort of dive into then your practice and the ideal patients from there.
I think it's a wonderful question. For many years, we felt the skepticism to offer focalized treatment as a standard of care. And if you ask me, make a lot of sense. If we go back a little bit in the US, HIFU, for example, high intensity focused ultrasound, was approved for prostate ablation about 2015. That means that before that, many patients went abroad where the urology who was performing the treatment was not doing the follow-up. So the indications, the way that the procedure was done varies a lot of. And of course, the patient came back to the local hospital to do follow-up, sometimes delaying the diagnosis of the potential recurrence. And also, we know the difficulty to set direct comparison between any kind of focalized or partial treatment of the prostate with radical prostatectomy. So we all know that in the future, if we want to incorporate like a standard of care for prostate cancer, we will need that randomized control trials. And believe me, as you know, many effort has been done. I just want to point out two from the Oxford and the UK, the PART trial comparing prostate ablation and radical prostatectomy. The problem was like almost 30 patients that was enrolled in the radical prostatectomy arm was not willing to accept that kind of treatment. The same happened in the FART with focal ablation radical prostatectomy from Norway that failed in the recruitment. I'm just highlighting how difficult, because this comes from the patient-driven procedure. We have to hear what our patients are telling us, that are very interested to preserve the quality of life. Of course, not compromising the oncological control, but with that, we face a big barrier to try to plan randomized control trials that prove the efficacy. So answering your question, currently, AUA guidelines does not support focalized ablation of the prostate as a standard of care for prostate cancer. The recommendation is that the treatment must be delivered under the clinical trial or a registry. And I just want to make a quick distinction. In clinical trials, we follow the protocol that we agreed on. Registry, on the other side, the urologist who is performing the treatment must keep a registry of the patient, and our clinical judgment tell us what barriers I'm gonna record. And in our clinical practice, it's very frequent that we keep that kind of records. For many years, the knowledge about focalized treatment came from Europe and Latin America. During my time there in Latin America, I was able to test, investigate, and also have a better understanding about the energy that we're using. The reason why I'm bringing you this up is because nowadays the European guidelines are a little more advanced, offering this kind of treatment, just keeping a registry. I would say that we have good data that support, one, the functional outcomes. And we have medium-term data that in very well selected patients with intermediate prostate cancer, how safe is the oncological efficacy of this kind of alternative?
So tell me a little bit, in your practice, I realize everyone's a little bit different, but in your practice, what would be considered sort of the ideal type candidate for focal therapy? And I'm just asking you specifically as somebody who does this a lot. I realize that this is not a blanket statement that may be applicable to everybody, but for your own sort of personal practice, your risk tolerance, what's the ideal patient for focal therapy?
The patient who is seeking candidacy for focalized treatment must have a unilateral cancer. Unilateral, we found that between 20-30% of our patients must have a clinical significant disease. That means some pattern 4, that we know how safe is grade 1 prostate cancer put on active surveillance. So greater than that with some pattern 4, we start thinking in some kind of treatment. Third, the volume matters. I mean, if you think carefully, a volume that involves up to 1/4, 1 out of 4 of the prostate size should be a candidate for focalized treatment. It's important the location must be isolated for important structure, must not be in close proximity of the external sphincter. of the neurovascular bundles and the bladder neck. Of course, will depend of the source of energy that we have available. For example, if the HIFU that we will discuss, I'm sure, that is applied from posterior, but if the area with cancer involved with aggressive cancer is in the top of the prostate anteriorly, probably I'm going to offer a different radical treatment and not a focalized treatment. Finally, we need an involvement of a dedicated radiologist. Why? Because we have to rule out risk of gross extraprostatic extension, seminal vesicle involvement. That means a more high-risk feature, and that means that the patient is going to be better served using a radical treatment. I just want to make a quick comment that we are seeing a lot of EPE suspicious in the MRI in my clinical practice. If I see a bulging, I can offer safely focalized treatment. The only reason that the patient seems not a candidate for focalized treatment is when we see a gross extraprostatic extension according to the MRI.
Mm-hmm. Mm-hmm. So, and maybe just to close out this section on patient selection, how does do biomarkers play a role in how you assess patients for applicability? And what about AI? I mean, I think that there's certainly a lot of interinstitutional variability with regards to our ability to map out disease. I mean, I think it's well established that even within the same institution, maybe the level of expertise of the radiologist may give you different interpretations. So is AI potentially an opportunity to standardize some of this? And also, what about biomarkers and how does that play a role?
Mm-hmm. I think that in terms of genomics and biomarkers, we have work to do. Of course, we have some idea and plan to work about that, but we don't have a clear answer what it's going to be or what is the role of genomics at this time. Mm-hmm. In my clinical practice, currently I'm using to determine which patient is safe to continue on active surveillance or the patient must jump to some active treatment. But I received the question a lot about in the patient that needs active treatment, how I manage the genomics. I think in a study that is currently going, we will have that answer in the future.
So, as you and I were sort of talking about this podcast and how to sort of construct it, I think one of the things that we both agreed on was that focusing on one specific energy modality probably wouldn't be accurately capturing the way we should be thinking about the disease and really understanding the concept of prostate cancer, the dominant lesion, mapping it out, focal therapy, and then obviously treatment benefits potentially with quality of life were important to recognize. But now I am going to take you a little bit to treatment options and what are the different delivery mechanisms of energy and maybe just talk a little bit about maybe the pros and cons, broadly speaking, of some of these different modalities.
In terms of the AI for prostate cancer management, I would say that in focalized treatment will have an important role trying to determine the margin of the area that we are going to treat and also trying to addressing the follow-up. As we all know that the PSA is not reliable tool as a follow-up after focalized treatment, and the MRI interpretation, it's very difficult after focalized treatment. With more knowledge and the utilization of the AI, I would say that it's going to be very helpful for us and our radiologists in trying to determine which patient and develop a recurrence after this kind of treatment. In relation to the energy source that we use, the first comment that I would like to say that we need at least I would say, two sources of energy in order to increase the volume, and that means increase your knowledge and experience with focalized treatment. What I'm referring to is that we cannot have an inherent bias that we all have as a doctor and try to offer the same treatment for all of our patients. We train a lot of years in our residency and early in our practice to perform radical prostatectomy, robotic radical prostatectomy. So our bias is, of course, if I train a lot of years to do something, I'm going to try to deliver the treatment that I'm mastering. We cannot make the same thing with focalized treatment. So if you ask me what is the ideal source of energy, must be simple to operate. That means the software, the machine must make my life easier during the treatment. Secondly, must be very precise. As we mentioned, some patients are accepting the uncertainties about the oncological management, and the trade-off is offered them, good functional outcomes instead of very low urinary continence and very low erectile dysfunction. So we need a source of energy that is very precise. Third, we need some real-time feedback to know exactly if we were able to complete the job or we have to go 2 or 3 times in order to increase the efficacy. And third, I would say that retreatment capabilities is some of the strength of the focalized treatment. And we can discuss which patient is a good idea to offer a second treatment, or we have to move forward with a radical treatment. So going deeper of the different energy, first disclosure, my experience, my knowledge, it's been for years using high-intensity focused ultrasound. And the reason for that is I like because I can shape very well the treatment area. The downside, I would say, that I cannot go very wider. But if you ask me, I don't want to, because if the patient has extremely big volume in the prostate, probably I'm gonna recommend whole gland treatment instead of focalized treatment. Mm-hmm. There is several energy that we can reach the prostate in interstitial approach. I'm thinking cryotherapy, development of ice ball to freeze the prostate. It's a good energy, and I would say the pros of cryotherapy is that it's one of the grandfather of focalized treatment. Mm-hmm. For many years, the experience came for cryotherapy. The main advantage is that we can go wider, especially in the anterior aspect of the prostate. The downside, I would say that we use urethral warmer catheter and rectum catheter to warm the rectum wall, decreasing the efficacy near that structure because we have a higher temperature. We are having more and more knowledge about irreversible electroporation or nanoknife. It's an energy that currently we are offering here at the Cleveland Clinic. The main advantage of that is that it's not thermal, meaning that you put 2 needles and we deliver electrical current between the needles. The fact that it's not thermal means less inflammation, so less side effects in terms of urinary retention, sloughing, that sort of things. And of course, there are new ones that is mixed with nanoparticles using gold, laser-like magnetic field. In the future, we are going to see more and more energy that currently it's being testing mostly under clinical trials. For example, water jet ablation of the prostate, steam using the concept of resume for BPH, we are going to see more and more data, but nowadays it's in the phase of the clinical trials.
So you mentioned a little bit earlier on, very accurately, that PSA really can't be used necessarily solely as a surrogate for treatment success. Obviously, if it's focal therapy or even hemigland ablation, you are going to get PSA secretion, obviously, from the untreated tissue. So talk to us a little bit about how do you incorporate PSA imaging as well as biopsy to determine after treatment your effectiveness, your treatment effectiveness.
As you mentioned, normal prostatic tissue produce PSA. So as you build your experience delivering focalized ablation of the prostate, you find the balance between more area treated, significant drop in the PSA. At the same time, with more area that is being treated, you decrease the risk of recurrence down the road. The trade-off is that you can impact the functional outcome of the patient. That is one of the main reasons why we are doing this. So there is no plenty of data to try to understand how significant it's going to be the drop in terms of the oncological efficacy during the follow-up. In my clinical practice, most of the time I'm aiming in a reduction between 40-50%, but it's again will depend how much PSA was produced by the dominant lesion, compare how big the prostate is, and how much is being produced by the untreated area. There is a good report from France that determine if the PSA drop less than 1.6, the patient should be fine in the next few years. That data has not been replicated because the problem to design a test like this. So what I'm hoping is a drop of the PSA 3 months after the focalized treatment. As we know, the inflammation will produce a jump in the PSA. So 3 months after the focalized treatment, a drop. And then what I'm looking for is some stability over the time. Our follow-up protocol is with a PSA every 3 months and an MRI and biopsy 1 year after focalized treatment. If earlier, sooner than 1 year, I see an uptrending in the PSA level, I pull the trigger first and I do the MRI and biopsy sooner than 1 year.
No, I think that's very well stated, and I think you hit on the key elements, which is using PSA, but understanding the limitations, using MRI, especially since these patients inherently would have had a pre-treatment MRI, so you have a comparator. And obviously, I think using biopsy to clearly identify that you've been able to kill the cancer in that area. So maybe two brief questions as we sort of finish our podcast. The first is, what are your criteria for retreatment? And I realize there's two types of retreatment, right? You could retreat, for example, somebody develops contralateral disease. That to me is just a natural history of disease that is now showing up in a different part of the prostate. And that to me is a little bit different than a treatment zone failure, meaning somebody with biopsy-proven disease. Tell me how you think about each of those two scenarios, both of which broadly fall into the realm of, recurrence of disease.
Finishing our last comment about the follow-up, I always teach my residents and fellow that we try to do an almost perfect workup in the diagnostic pathway. We take a good care of the MRI slide by slide. We try to do our best using fusion biopsy platform in order to precise target. But after the focalized treatment, the concept remains the same. We have to look for it if we want to find it. One of the disadvantages of focalized treatment is that if we don't find the recurrence, that patient will have either positive margin and potential surgery or even metastatic spread. So I'm always very careful to put the same effort looking for the recurrence after the focalized ablation that we did for the diagnostic pathway. During the follow-up, sometimes it's overwhelming, especially if you are thinking to start your focal therapy program, how we are going to determine either candidacy and a good follow-up. And I would say that in our experience, building a focalized treatment tumor board in order to discuss the patient already treated and the patient that looking for candidacy for focalized treatment was a game changer. Because, decrease the cowboy decision who has the louder voice, we will get the patient either radical prostatectomy or focalized treatment. But in the follow-up, it's very important because the radiology can match PSA drop and how the patient is going with the MRI that we are seeing. So I would say it's very important to determine, which patient are having some recurrence of the prostate cancer, and also to advise the patient better how are going to be treated. Most of the time when we have infill, we call infill in the area that was treated, was an energy failure. Probably the energy was not able to safely kill all the area that I was hoping. It's a technical thing. Mm-hmm. And most of the time, for example, for HIFU, is the anterior location. Mm-hmm. For any other surgery, for any other source of energy, is the apical lesion, is the apical location. We are very respectful of the external sphincter. So we try to preserve that area, increasing the risk of recurrence in that area near the external sphincter. When we see outfield recurrence, outfield cancer in area that was not treated, in my clinical experience, 80% of my patients tell me, okay, Dr. Olivares, can we do that again? Because it looks like, of course, it's a surgery. It's not a sip of water. It's under general anesthesia. You have to use a catheter. But most of the patient goes very well. If the patient has a recurrence, have more cancer, significant cancer in the contralateral area, for sure, I'm going to recommend focalized treatment again. The margin of the ablation is a different talk. What I'm saying is that if I can reach the area using focalized treatment, I'm going to counsel to repeat that. But since we already trespassed our learning curve, if the patient at the first time didn't go great, probably it's because the presence of some calcification, presence some cyst, rectum wall thickening, or if you are using cryotherapy, it's that you are too close to the urethra. So I'm not sure why a new same source of energy treatment is going to have a different outcome.
Well, that's really great. And Ruben, I really appreciate you taking the time this afternoon. It's really, I think that this is certainly, as time goes on, a treatment modality that our patients are looking for. I think it's paramount that it be offered in a very thoughtful way. I always say we don't want to use this as a reason to treat disease that doesn't need to be treated. Similarly, we don't want to use this to treat disease that shouldn't be treated by focal therapy, but as you alluded to, whole gland options, whether that be radiation or surgery. So I really appreciate you taking some time to talk to our listeners and educate us on the role of focal therapy for prostate cancer and some of the nuances. So thank you very much in advance.
Thank you. If I conclude this podcast, and again, Dr. Raman, thank you for having me here. I would say that focalized treatment has a huge potential role in localized prostate cancer. We have a better understanding. We are not starting from the square number one. AUA Annual Congress has two courses in order to understand how the safely way to deliver that. We can all agree that the functional outcomes, it's way much better than our current option, either radical prostatectomy or radiotherapy. Oncological outcomes, we need more time. But if I may say, medium-term outcomes show very similar compared with the standard of care. I really like that the skepticism of many urology against focalized treatment, because that gives us an opportunity to improve. And that's why registry, it's very important, because with registry, we can start getting more and more report of our outcomes, and that the only way that in the future AUA guidelines will incorporate focalized treatment as a standard of care.
Well, thank you very much. And certainly to our listeners, we thank you for your time and your attention. We do encourage you to visit us at auanet.org/university, and certainly to the core curriculum chapter, which delves into this concept and many others in greater detail. It was wonderful catching up with you, and I hope to see you sometime again soon in person.
Thank you. Thank you very much.